Thank you so much, Dr. Somerville, for these kind words. I'm humbled and honored to be here today. Thank you for the introduction. Thank you, Professor Gatzoulis, for selecting me for this Royal Brompton Paul Wood Visiting Professorship Lecture of 2022. This lecture is indeed named after Dr. Paul Wood, and I'm sure that no one in this room, except for Dr. Somerville, was fortunate enough to meet Dr. Wood. So we need to rely on the written word, and it was Dr. Somerville who wrote in '98 the following about Dr. Wood. It's the man who had made clinical cardiology precise by diagnosis based on correct physiological principles, and had raised and established the standards of practice of cardiology, particularly at the bedside for the world. And to a certain extent, that was also the spirit and the concern that she just expressed. And indeed, this 2022 lecture is dedicated to Dr. Gary Webb. I was fortunate enough, like many of you, to meet Dr. Webb. And he was a true leader for our community. And the following words have been written by the doctors Ushlin, Coleman, and Alonso. Dr. Webb has been a global authority in ACHD clinical care, in guideline development, in knowledge transmission, and in creating an enduring global network of like-minded individuals, working towards the goal of improved understanding of ACHD and improved care for those born with this lifelong chronic condition. The future of the global ACHD community is built on his legacy. And indeed, in the presentation of today, I'd like to bring in the spirit of Dr. Wood and Dr. Webb and show that the work that we are doing today in the ACHD, in the GUJ area, is by standing on the shoulders of these giants. To start this presentation, I'd like to show you a video. It's actually a video that made a strong impact on me. It's a video, a presentation, a TED Talk given by a Dutch neurologist called Bas Bloem. He is a neurologist working with Parkinson's patients. And the title of his presentation is From God to Guide.
Another busy day in the clinic. Let's see what we have today. Where is this? All right. First patient, please. Hello, what can I do for you, sir?
Yeah, doctor, my right hand is trembling a lot. I'm very sick about it. Can you help me, please?
It looks just like Parkinson's disease. You know what? Why don't you take levodopa carbidopa, 62.5 milligrams, 3 times a day, not with the meals, mind you, and I'll see you again in 3 months' time. Here's a prescription.
Doctor, please, you have to take me seriously. This is very bad news. It will change my life completely. I want good and reliable information. And I want to have part in making the decision to start treatment or not. And where can I find another patients like me? What can I do to make things better? So, this kind of medical care is not the reason that you once became a doctor, is it?
Hans, follow me. Let me tell you a little bit about Parkinson's disease, all right?
Okay.
Come on, have a seat.
Where shall I sit, doctor?
Hans, in the world you've just created, there is no more hierarchy. So take any seat you like.
Oh, I take that one there.
I've purposely removed the desk from my office because this is really working together in the healthcare system. And I want to tell you a little bit about Parkinson's disease, and I'm going to show you a video so you know what it really looks like. And I'll also show you the video because it shows you the power of patients and their ability to compensate for the disease. This is a nice little tool that was given to us by the Reshape team in Nijmegen. So, can you see this properly?
Yeah, okay.
All right. So we'll start the video now. It's a man with Parkinson's disease who's had the disease for a long time. Yeah, just move it. And as you can see, he has severe difficulties walking. But in the office, this man told me he was actually able to ride his bicycle.
Wow.
And I said, that's impossible.
Yeah.
You see, he's severely handicapped, but he told me he was able to ride his bicycle. Mm-hmm. So we decided to take him outside and see what it looked like. Because I was surprised by this message. I said, you know, this is impossible.
And this is not possible, I think.
You think it's possible?
I
that
don't
this
think
man...
so. No, I don't think so.
Well, there he is.
Oh, wow.
We went outside and have a look. And we were just as surprised as you are probably now.
Yeah.
Isn't that amazing?
That's amazing, yeah.
And I think I'm showing this video to you because patients have a huge power to compensate for their disease. So even though patients have, of course, severe difficulties, they have remarkable abilities left. And that's the reason I'm showing this video to you. Look, here, he climbs on the pedals. You see that?
Yeah.
Isn't that amazing?
And that's very amazing.
And luckily, he returns. Huh?
Yeah, of course.
And look at this. This is actually the best part of the video. Look at this. There. Hop!
Up a day. Yeah.
But now he's stuck again. He was immediately frozen to the ground.
Yeah.
And you know what is remarkable?
Oh.
I had never seen this before, but I received hundreds of emails from all around the world by patients, just like this, who had a remarkable ability to compensate for their disease. And you know what? They knew it all along, but we didn't. It was staring us in the face all the time.
It's remarkable, yes.
Is it clear to you now?
Yeah, I know. It's clear, yes. Thank you.
Is it all right if I take the podium and spend a few minutes talking to the people, explaining what we should do?
You may go.
Okay, I'll be back with you in a minute.
Thank you.
Ladies and gentlemen, what you have just seen is a remarkable transition in a few minutes' time from a doctor who once was a god in his ivory tower, or actually in a yellow forklift. And I think it is time that doctors descend from their ivory tower and become a guide, a coach in the life of patients. We would like to call this participatory healthcare to exemplify that this is a world where doctors and patients are working together on a mutual basis. Of course, the roles are different, but we have mutual respect and we collaborate with each other. And make no mistake, this is not a world where patients are ruling, where patients are bossing their doctor, which is what some of my more conservative colleagues are afraid of. This is not what patients want. Patients want to be taken seriously. They want to take actively part in the process. And this is neither a world that is dominated by ICT or gadgets. I think the tools that you've just seen are helpful in supporting this new type of care. But it should always have one goal, and one goal only, is to serve warm human contact. Because that is what patients are waiting for. And then ICT and all sorts of other technologies can serve that main purpose. Now, if you are still hesitating whether or not you should make that transition yourself, let me just give you a few good reasons. We've heard it today. One is hospitality. I think we should really start to see our patients as clients. For them, a visit to the hospital is an experience. And if we just treat them in the way the bus driver that we've seen earlier today was treating his guest, if we start treating patients this way, I think we're going to make a huge move in the healthcare system. The video of the patient on the bicycle, to me, is a huge source of inspiration. And I am surprised, week in, week out, by the power of patients, how they compensate for their disease, how they battle all the difficulties they encounter every day in their life. And I think today we've seen wonderful examples of all the patients that have been here today, showing their power. And I think we are underutilizing that power. And we still think that patients should be treated as passive objects rather than an active subject who can contribute to their own health. And if you're still hesitating, and if not for any other reason, engaging your patients is cost effective. Let me give you one wonderful example. What I normally do in my clinic is tell my patients to come back after, say, 3 months. But if things go bad, 3 months is too late. But if you're doing fine, 3 months is too early. So they've done a randomized clinical trial where in one arm of the study, the doctor traditionally said 3 months, 6 months. And in the other arm, the patients were left free to come back whenever they felt the time was right. And do you know what happens? They come less often. The number of no-shows goes down. And the patients are always just on time because they decide when to come back. And I think those are just wonderful examples of how engaging patients is a way to maintain the quality of care and at the same time reduce the costs. And then finally, and we've heard it today, it is a choice. I chose my job because I'm passionate about healthcare. I have compassion for my patients. For me, seeing a patient as a partner, as a sparring partner in the health process is the only way. I cannot see any other way. And if we start to treat patients as active subjects, working for me as a doctor becomes so much more pleasurable. It becomes so much better, more effective. And again, I think in fact, it's almost not a choice. I think it's the only way to move forward. So I tell you, I have a wish cookie, a secret wish cookie. But that wish cookie I want to share with Hans, because Hans is a real patient of mine. He has Parkinson's disease. And I think it's amazing that Hans is here. And Hans, why don't we open that wish cookie together? What do you think?
That's a good idea.
Shall we press the button? There we go. It's participatory health for all of us. We want to thank you.
Let's do it all together.
This video made a huge impact on me. And especially because this is, in fact, all about person-centered care or patient-centered care. And it was already in the early 2000s that the Institute of Medicine in the United States published this document, Crossing the Quality Chasm. And it was indicated in this document that quality care has to do with safe care, effective, timely, efficient, equitable, and also person-centered. And in this document, person-centered care, or patient-centered care, I should say, is defined as providing the care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. I was referring to person-centered care, whereas you also read patient-centered care. Patient-centered care is actually was the first term that was used. Nowadays, the term person-centered care is more used. And the reason for that is that by using the term patient-centered care, we already reduce the individual to being a patient. And instead of that, and that's the argument for person-centered care, we should look at this individual as a person. And health and the need for healthcare is only a small part of the life and what this person is all about. In this presentation, I will refer to patient-centered care as well, but know that indeed we should rather have the perspective of person-centered care. The Picker Institute, which is an American institute, is one of the first institutes that was really focusing on patient-centered care and what should that entail. And these 8 dimensions are characteristic for patient-centered care according to the Picker Institute. Fast access to reliable health advice, effective treatment delivered by trusted professionals, continuity of care and smooth transitions, involvement in decisions and respect for preferences, clear, comprehensible information and support for self-care, involvement of and support for family and carers, emotional support, empathy and respect, and attention to physical and environmental needs. In this presentation, I will have a particular focus on one hand, the involvement in decisions and respect for preferences, and on the other hand, the involvement of and support for family and carers. And these 2 things actually have all to do with a big demand that patients have towards us as healthcare providers. Nothing about me without me. We are talking all too often above the heads of the patients, and we are involving them too little. And to make it more precise, this statement, nothing about me without me, to make it more precise, there are 4 requirements. Requirements that patients have towards us. These are inform me, engage me, empower me, and partner with me. And I'd like to address these issues. Inform me has to do with the typical provision of patient education. And indeed, we are doing research on the level of knowledge of our patients, on how to provide education, which domains should be included, and so on. And this research is ongoing since 2-3 decades already. Domains that are indeed important in this patient education are providing information on the heart defect, treatment, health behaviors, preventive measures, sexuality, reproduction, lifelong medical follow-up, and so on, and so on. And what is good after 2 or 3 decades of research, that in the meantime we also have evidence that patient education is working. Indeed, we are able to improve the level of knowledge of patients by using structured educational approaches. The second domain has to do with engage me. And what is important here is that when we are developing our programs, the GUJ programs, follow-up programs, and so on, we seldomly listen to our patients and hear from them what is precisely what you need, what is what you want from us. We develop it rather from an offer point of view, what we can offer to the patients rather than what they need in the care. And therefore, it is extremely important to listen to patients, to listen to patient representatives, And we can do that by doing qualitative research, doing interviews with patients, with family members, in a sense like, what do you have? What do you experience in the care today? What are you missing? What do we, how can we do better? Another element is, for instance, having an advisory board where patients are represented in. And what is important to know, and I think in Europe we can learn from that, in the United States, the accreditation of ACHD programs is done by the major patient organization, ACHA. And when professional auditors are working together with patients, you have a better perspective on the quality that is provided. So patient engagement in the development of programs and in the evaluation of programs. When you're looking at the transition of care, going from pediatrics to adult care, and to what extent is the healthcare provision youth-friendly, there you can work with youth panels or youth ambassadors. Some years ago, I was in Copenhagen, at Copenhagen University Hospital. They do have youth ambassadors, and it's this group of ambassadors that is advising the management on how can you make your hospital more youth-friendly? What do we need as youngsters? We need a separate room where we can hang out, where we can meet peers, and so on and so on. This is a very strong element to make care more appropriate to the needs of the patients. Another element talking about these transitional age patients is we need to make sure that we are addressing these things that matters to adolescents. And the HEAD system is typical for that. HEAD stands for home, education, activities, diet, drugs, depression, sex, safety. When talking with young people with congenital heart disease or any other chronic condition, we need to make sure that we are addressing these things, because this is what matters in their life. And it's by understanding these factors that we better understand why are they behaving like they behave? Why are they not showing up on the consultation? If we have an understanding on what is happening in their social life. Empower me. That's the third request that patients have to us. Empowerment is a very fascinating concept. There are different definitions on that, but one of the most comprehensive and informative definitions, I think, is the one developed by Nicola Small in Manchester. And she defined empowerment as an enabling process or outcome arising from communication with a healthcare professional and a mutual sharing of resources over information relating to illness, which enhances the patient's feelings of control, self-efficacy, coping abilities, and ability to achieve change over their condition. Based on the work that Nicola Small has done, we know that empowerment entails 5 different domains indicated here: knowledge and understanding, personal control, identity, shared decision-making, and enabling others. And again, knowledge and understanding, this brings us back to inform me, the aspect of patient education that I was talking about some minutes ago. So by providing education to patients, we are not just improving their level of knowledge, we are enhancing their level of empowerment as well. And you can indeed wonder, why do we need to empower patients? Is it just for the sake of empowerment? That would not be a good reason. Well, in the beginning of this year, a review that I did with my colleagues in Sweden was published, where we were looking at definitions of empowerment, but most important, what are the correlates of empowerment? To which factors is empowerment correlated? And this is actually the overview of the study. The black dots, as you can see, refer to the number of times that a certain association has been investigated, and the blue bars refer to the percentage of studies that found a significant relationship. And indeed, as you see here, health status, stigma, self-efficacy, and self-esteem were 100% found to be significantly correlated to empowerment. Other factors that were highly correlated were quality of life, psychiatric symptoms, social support, diabetes complications, self-care, level of functioning. So this means that empowerment can be an intermediate outcome, an outcome that we can try to improve, and indirectly we may have an impact on perceived health status, on stigma, self-efficacy, and so on. And it is for this reason that it was not surprising that once that we were developing the global statement on transition to adulthood and transfer to adult care for adolescents with congenital heart disease, that we stipulated that the main outcome should be empowerment. And once again, because this is the kind of the intermediate outcome to reach more distal and probably more important outcomes such as quality of life, self-management, disease knowledge, continuity of care, and so on. The question that is coming up then is, okay, but empowerment, can we really improve the level of empowerment of our patients? Well, I'd like to present to you the results from a randomized controlled trial that I've done together with my colleagues in Sweden. Like Dr. Somerville indicated, I'm from Belgium, but I hold a joint position at Gothenburg University in Sweden. And it's there that we did the Stepstones project, standing for Swedish Transition Effects Projects, supporting teenagers with chronic medical conditions. And the aim of Stepstones, of the first Stepstones project, was to investigate the effectiveness of a person-centered transition program for adolescents with congenital heart disease. This study was a randomized controlled trial conducted in 7 pediatric cardiology centers in Sweden, indicated here. The design looked as followed. It was a 3-arm design. First, we had 2 centers that represented the randomized control group. In these 2 centers, patients were randomly assigned to the intervention group or the control group. With this kind of complex interventions, you always have the chance or the possibility that there is some contamination in the control group. And to control for that, we had what we called contamination check control group, which was conducted in 5 centers where no intervention was conducted at all. So the risk for contamination there was nil. The Stepstones intervention program comprised 8 components, having a transition coordinator, a written person-centered transition plan, information and education, availability by telephone and email, information about and contact with the adult clinic, guidance of parents, meeting with peers, and the transfer to adult care. And indeed, empowerment was the primary outcome in this study. And of course, you need to have a good mechanism. How are you working on this level of empowerment? And that was the main task of the transition coordinator. This transition coordinator was trying to make sure that patients were well informed about health, cardiac diagnosis, treatment, and follow-up, that they felt confident in their ability to manage their own illness, to develop a better self-esteem and improve the ability to talk about the diagnosis, about their heart defect, take control over health and illness, because as a child, it was their parent or their parents that were responsible. Now they have to become the manager of their condition. And finally, to improve and develop the skills to make well-founded and hopefully healthy decisions. Like I said, the primary endpoint was empowerment, which was measured with the Gothenburg Young Persons Empowerment Scale. Secondary outcomes were transition readiness, patient-reported health, quality of life, health behaviors, disease-related knowledge, and patient uncertainty. The findings of the Stepstones project were presented at the ESC conference last month, so they are no longer under embargo, and I'm happy to show you that indeed the Stepstones transition program was able to improve the level of empowerment in the patients. The mean change over a period of 2.5 years was 6.4 points in the intervention group compared to 2.97 in the control group. And the difference in mean change was statistically significant. Looking at the secondary outcomes, significant differences were found for parental involvement, which was decreasing over time, and the level of decrease was higher in the intervention group than in the control group. An overall higher transition readiness, better appraisal of physical appearance, and better disease-related knowledge. No significant differences were found on the variables listed here at the right column. Let's come to the last part, or the fourth request from patients to us, and it has to do with partner with me. And this is what person-centered care is all about. And once again, working in Sweden, person-centered care is high on the agenda there. And Gothenburg University has a center for person-centered care, and they also have developed a specific model comprising 3 pillars. Initiating the partnership, which accounts for the patient story. Listen to the patients, what their life is all about and what they expect from us as healthcare providers. Work with this partnership, and that has to do with the shared decision-making, and safeguard the partnership, make sure that the story of the patient is documented, that it is clear that the person-centered elements are taken care of. So the care, there is room for improvement. I think everyone, if we look at how care today is provided in our own center, in other centers, there is room to improve these 4 elements. But also regarding research, also research should and could be more person-centered. And one of the first initiatives was done by PCORI, which is an American initiative. And PCORI stands for Patient-Centered Outcomes Research Institute. And their main task is to make sure that research is done differently in a sense that patients are involved in research and that patients' needs are the trigger to drive research. At this side of the Atlantic, we have the James Lind Alliance. And James Lind Alliance is actually an initiative where patients, carers, and clinicians are brought together to develop research priorities together. And such priority-setting partnerships, because that is what it is all about, these enable clinicians, patients, and carers to work together, sit together, work together to identify and prioritize uncertainties about effects of treatments that could be answered by research. And what is the effect of initiatives like this? Well, effects of treatments, we can roughly divide them in these 3 groups. Treatments that have to do with drugs, vaccines, or biologicals. Treatments that have to do with radiotherapy, surgery, perioperative care devices and diagnostics, or treatment that has to do with education, training, service delivery, psychological therapy, physical therapy, and so on. If you then look at commercial trials, non-commercial trials, and patient-clinician priority settings, in commercial trials, no surprise, the large majority of the studies have to do with evaluation of drugs, vaccines, and biologicals. If you look at non-commercial trials, it is more mixed. All three of these types of outcomes research is represented. When you look at research that is the result from patient-clinicians' priority settings, it looks like this. And I think numbers like these are compelling. It shows when you really ask patients and clinicians to work together to decide what should be investigated, we would have a completely different scene in research. A scene that is definitely much more person-centered, much more patient-centered. Questions that are addressed then would be, what are long-term effects, wanted or unwanted, of the treatments? What about the safety and adverse effects of treatments? Complementary and non-prescribed treatments, early diagnosis and treatment of harmonization of practice, and self-care. And to a certain extent, and this is a call for the researchers in this group, and it's also a note to myself, science and research is not always having a good reputation, because it is often seen that researchers are doing things that they think is important, but which is not necessarily important for society. Look at the debate that we had about vaccinations and COVID measures and so on. So in society, there may live a feeling that society is one thing and science is another thing. If we are involving patients in setting the priorities, we bring science to the society. And I think this is an extremely important thing to do. This is the way we have to move forward. Let me come to the conclusion of my presentation. And it's a very easy take-home message that I want to give you. You only need to remember these 4 things that patients expect from us: inform me, engage me, empower me, and partner with me. And I'm sure if we are able to do so, Dr. Repp and Dr. Wood would be proud, because then they see that their legacy is used in a very useful way for the benefits of our patients. Thank you so much.